in stage 3 disease, again, to reiterate the fact that even though many patients are tested for various molecular markers, as well as PD-L1, we don't know exactly how to use those. So in my practice, I'm kind of agnostic to those outcomes, even though I can tell you that in our system at my cancer institute, many stage 3 patients do undergo testing for PD-L1 as well as molecular testing. If the plan is to do chemoradiation in stage 3 patients, then I don't know how to use the information regarding the molecular markers and PD-L1 status to change anything that I would do. I think the PACIFIC data, which included all patients regardless of PD-L1 status, that benefit you see from checkpoint inhibition has to be assumed for all patients. And we don't have enough granularity in information from the PACIFIC trial to say that you should exclude this patient or that patient. No, all patients should be assumed to get benefit. In this particular patient, because they had multi-station bulky N2 disease that was proven at the time of EBUS, that I don't think that surgery plays a role in this particular patient. We have at least 2 randomized trials in patients like this that have evaluated the role of surgery, and neither one of those trials has shown a benefit to the addition of surgery versus chemoradiation. So I do not think that surgery plays a role in patients with bulky multi-station N2 disease, that those patients are best managed with chemoradiation. And I say to patients, because many patients feel, well, if I can't have surgery, I can't be cured. I say, no, that's not the case. Surgery is not necessarily a part of your curative strategy. We know that we cure patients with chemoradiation, and we know that with the addition of checkpoint inhibition following concurrent chemoradiation, we actually cure more patients. One of the questions that Pacific has raised is should we rethink the issue of resection, in knowing what we know about the use of checkpoint inhibition based on the PACIFIC trial in those patients where, maybe borderline candidates for resectability. Would you defer to the PACIFIC approach rather than integrate surgery? I don't know. My bias is that the vast majority of stage 3 patients are unresectable, or even though they are technically resectable, we don't know that resection adds to their long-term survival. We do know that the addition of checkpoint inhibition after chemoradiation improves their long-term survival. We don't know that surgery does that. So I think that in centers or institutions where there's a strong surgical bias, I would advise them to rethink that. My bias for years in this disease setting is that surgery does not play a major role in the management of these patients. And if surgery is playing a major role, then I think you need to consider the PACIFIC results and kind of reassess what you're doing in this particular setting. Because again, surgery has never been demonstrated to improve survival. Checkpoint inhibition has been after chemoradiation, and we don't know how or if we should do checkpoint inhibition following surgery. Those are trials that are ongoing, vitally important trials. If you have the ability to accrue a patient to the trial, you should, so that we get an answer quicker. But right now in the surgical setting, we don't know how to use the checkpoint inhibitors.